Good day. My name is Dr. Lloyd Gayle. I am the Vice Chairman of Surgery and the Co-Director of the Division of Plastic Surgery. I'm board certified in plastic surgery and have a specialty area in microsurgery. Well, I completed medical school in 1983 from NYU, and thereafter I completed a general surgery residency at Booth Memorial and at NYU. Thereafter, I did a fellowship and plastic surgery residency training program at New York Presbyterian Hospital. And then finally went out to San Francisco and spent some time with a gentleman by the name of Harry Bunke. Harry Bunke is really the grandfather of microsurgery in the United States, and trained with him for a year, and then returned to Cornell and joined the faculty and was on faculty since 1990 at Cornell until just recently, and recently joined the faculty of Maimonides. Well, plastic surgery is a unique specialty in that it's a combination of the restoration of tissue, it's rebuilding tissue. It approaches patients a little bit differently in that we're not disease-centric, but we're really problem-centric, looking at whatever the deficit is in the patient, whether or not it's the absence of a breast, problems associated with radiation therapy, and or disease. And so it allows you to bring to bear your general surgery training, the techniques of plastic surgery, the options of really trying to restore patients back to some semblance of whole. The special area of interest that I've maintained over the course of the last 15 years of my practice really has been the breast. I focus predominantly on breast reconstruction, the cosmetic restoration of the breast, either post-mastectomy or after congenital or other problems, and the aesthetic breast, that is breast enhancement, augmentation, reduction, breast lifts, the entire realm of breast surgery. A collaborative effort with the patient and with the other physicians caring for that patient is really critical to the post-mastectomy breast reconstruction. We don't work in a vacuum. I think it's critically important to listen to the patient and get a sense as to what the patient's goals are. I think all too often in medicine we impart our goals to the patient, and at the end of the day, the person who has to live with this is the patient. And so I think it's critically important that we listen to the patient and really try to gear a treatment plan and a final outcome that is suited to what that patient needs. Well, the current trends in breast reconstruction really are in two broad categories. One is the use of one's own tissue in the restoration of the breast. The transfer of tissue from the abdominal wall to the breast has been a tried and true technique. What's different in the course of the last 10 years is that we're far less destructive to the abdominal wall now, and there are techniques that involve transporting that tissue in the absence of destroying the muscles of function of the abdominal wall, and that's one of my areas of expertise. That's a procedure known as a DIEP or DIEP Flap. On the implant side, there are new implants that are coming down the pike, restricted now by the FDA, but hopefully soon to enter the mainstream. And these are implants that are and have been on the European market since about 1993, 1994, that are shaped silicone implants that really are the gold standard, if you will, for today, I think, of implant reconstruction. These are implants that are contoured, that are very much the same shape as the natural breast. They give a tremendous option or variety of implants to choose from that match the base width, the height, the projection of the breast, and so it allows almost a customized implant reconstruction. That's an implant that's limited in terms of availability. There are approximately 120 surgeons across the country who are currently using them. I'm fortunately one of those surgeons, and it's an implant that hopefully we'll be able to bring as part of a research study to Maimonides and be able to provide that to the patients in this community. Well, the main technique, as I said, is the DIEP Flap, and the DIEP Flap allows us to transplant skin, fat, in the absence of muscle from the abdominal wall, use a microsurgical technique that allows the blood vessels to be reestablished on the chest wall, and shape the breast in a manner that really provides a very natural feel, natural appearance, and at the same time provides the aesthetic benefit of what in essence is an abdominoplasty or a tummy tuck. So the patient derives a dual benefit, restoration of the breast and a recontouring of the abdomen, which is usually met favorably on the part of the patient. Well, I think that it's important to understand that, as I said, we are a compassionate office, one really focused at trying to listen to the patient and provide to the patient what they need. Beyond that, we have a very, very dynamic group in the office. My nurse, who's been with me now for some 15 years, is a phenomenal resource with respect to providing patient care, patient education. Her name is Pamela Messina. She's an integral part of my practice. I think that the capacity to really focus on all elements of the patient is part and parcel of why I came to Maimonides. We have, in the leadership of Dr. Borgen, a terrific surgical leader, and I think the combination of the ablative skills of the breast service, the reconstructive options that we now can bring to bear here, really provide a tremendous service to the hospital and to the community. My career has been one that's been built over time with patients and patient care, and I think that that combination really is the cornerstone to my practice. We're involved in a whole host of things. I travel abroad to take care of kids who are less fortunate than the kids here. We do cleft lip, cleft palate reconstruction, a fair amount of hand and burn reconstruction through Kenya, Thailand, Philippines. And so that's part of who I am, that's part of our practice. But I think the key is understanding that we're here to take care of the patients and here to take as good a care of the patients that we would if we were delivering care to our own families. And so I think that's really the cornerstone to our practice.